First of all, thanks for the kind invitation. And actually, this is more or less structural heart disease intervention, and this is one of the closest to my heart, actually. I'm going to talk about mitral paravalvular leaks. First of all, mitral paravalvular leaks has higher rates if compared to the aortic valve, 17 to 10%. And percutaneous closure is the treatment of choice, especially if the mitral paravalvular leak, if the patient has a stable valve and in absence of infection. We offer closure for patients who have severe PVLs or even those who have moderate but are symptomatic in the form of hemolysis or heart failure symptoms. And device closure may reduce and not completely obliterate the whole defect. And of course, the catheter option is more appealing as the mortality rates increases in those type of patient with successive reoperation. But be sure that you do not attempt mitral paravalvular leakage closure unless you completely understand the anatomy of the valve. You have an excellent procedural imaging team after multidisciplinary team discussion, and you are in a center experienced in all forms of mitral access. You have a full range of catheters, wires, and devices. Moving to the imaging modality, of course, a 3D TE is the gold standard imaging modality for assessment of paravalvular leaks for its a unique character in determining the accurate size of the defect and the shape, which is crucial for device selection. And also, it is necessary for the peri-procedural planning as the TE helps you to get the mitral valve surgical view, which is the 12 o'clock model. And consequently, it helps you to plan your access. As we can see here, that the aortic valve is at 12 o'clock, and then the left atrial appendage will be at 9 o'clock, and the septum will be at 3 o'clock. Whenever you have a defect which is from 8 to 10 o'clock, you can proceed smoothly from the transseptal puncture. Whenever you have a slightly anterior defect, you can take the retrograde approach from the aorta. And whenever you have a septal anterior or posterior defect, you should keep in mind the transapical approach. However, it is difficult. And finally, it is important during the guidance of the intervention of the cardiac interventionist during the procedure, whether to move anterior, posterior, medial, or lateral, just to put your catheter above the defect in order to be able to navigate it with your wire. Comes in the second position is the multi-slice CT, which is very important for identifying the imaging view, which will you work during in your cath lab. We can see here that the CT can make for you the visual angiographic images, where it can put also or create images for the mitral valve in the en-face view, and which is corresponding to the 12 o'clock model we discussed in the, or corresponding to the 3D TE. And also you can plan your transseptal puncture, and it can help you whenever you are going to take the transapical approach. And recently, the MRI 4D flow can accurately assess and do quantification for the severity of the mitral paravalvular leak. Step one, as we said, that the peri-procedural planning is of utmost importance, as you cannot proceed in your cath lab without knowing what will you do exactly. Then you proceed for the transseptal puncture, which should be the more superior and more posterior as you can, especially in posterior and septal defects. And then whenever comes the third step, which is the most difficult one, which is crossing the defect. And you should have a deflectable catheter in your cath lab, especially in the septal and posterior defects, such as the Agilis catheter, or sometimes we use the Medtronic Flex catheter, 12 French steerable sheath, which is used by the electrophysiological team. And then after choosing after using your deflectable catheter, you have to put the right angiographic views, the LAO view with some or no cranial angulation, in order to differentiate the medial or the septal part and the lateral part, and the lateral view, of course, to differentiate the anterior and posterior in order to be able to navigate your defect. And the third, and then moving to the third step, after you know your angiographic view, you have to have a good communication with the cardiac imager in the cath lab in order to help you to be able to navigate the defect, either move anterior, posterior, anti-clockwise, or clockwise. And finally, do again sizing of your defect in order to be able to choose the appropriate device. We all use before using the dedicated PVL devices, we use the pediatric devices, the VSD, PDA, and MFO. And unfortunately, those are currently dedicated vascular plugs, such as the Oculitech and AVP3, which only received CME mark for for PVL closure, is not available in Egypt. We recently used the cerebrovascular plug, which is designed for peripheral vascular intervention. We will rapidly go through some out-of-the-box cases from our CAS lab. This was a 56-year-old lady with severe septal mitral paravalvular leak, which has a right femoral vein obstruction. We decided to proceed for the transapical approach, doing the left ventricular angiography, then using the Seldinger needle to take the puncture through the intercostal space, passing the wire, and then the trauma wire, and then the stiff wire into the up to the pulmonary vein. Closing here, we can see that the defect was closed with a Conar device, but the only disadvantage that you have to use another device to close the apical defect. And this was a case for actually, what was challenging in this case is that was an 11-year-old child after stem resection and mitral valve replacement who had a severe mitral paravalvular leak. We crossed this smoothly, but you should be cautious while taking the transseptal puncture in a pediatric patient and closed it with a muscular VSD device. This was a 56-year-old lady with double valve replacement and a lateral large defect. And whenever you have a large defect and you may use two devices, you have to cross with the large 12 French delivery sheath. And if you have a rigid septum, you have first to balloon dilate the septum in order to be able to cross with two delivery sheaths and apply two devices, which were also MFO devices. This was a 56-year-old lady which has a transseptal PVL, but it was located slightly anterior. So we decided to cross retrograde from the aortic valve from the start, making the AV loop, and then finally deploying the muscular VSD device from the antegrade approach after obtaining the transseptal puncture. And this was a 52-year-old female who has a lateral serpingeous mitral paravalvular leaks. We crossed it, at first we couldn't cross it with the trauma wire, as it was a serpingeous defect, so you have to use first a PCI wire, which might facilitate the crossing of the trauma wire across the defect. However, after crossing, we can see here that the delivery sheath attained an upward position in the left atrium, and we couldn't deliver our device. So despite we made the AV loop antegrately from the venous side, we delivered the device from the retrograde side from the aortic valve. So some tips and tricks, as I said, if you have a large defect and you want to use two delivery system, go with a large 12 French sheath from the start. And whenever you are suspecting that this defect might need two devices, you might close the first with the first device and keep your wire inside. And here we can see that this patient was having a moderate paravalvular leak despite closure with the first device, so we proceeded with the second device. And the second tip and trick is that you can snare the wire, of course, from the aorta to give more support for your delivery system. And of course, as we all know, some paravalvular leaks, you might get another defect after 2 or 3 years. This patient had a device here at the septal site, and then we had to put another device at the lateral side. And despite he was having two significant defects, from the septal and from the lateral side, after we closed the lateral defect, and this goes with the mechanism that the device might interfere with the ring and the movement of the device. The second residual defect did not appear in the TE after closing only the lateral defect. And finally, be cautious not to oversize your device, as it might interfere and encroach on the valve leaflet. You might cross first with a PCI wire, and you can use two smaller devices rather than a large one, and use a larger 12 French sheath whenever it is a large defect. And finally, since you start doing this, you will be the surgeon's best friend, but be aware of the surgeon's gifts. Thank you.